When are you having a baby? Is a question that almost every couple gets at some point. For some, this question triggers good emotions of happiness, of joy, but for most, it carries a heavy pressure and years of silent and quiet suffering. So, today's episode, we're going to take that question and turn it into an honest, expert-led conversation about fertility, led by an IVF pioneer in the Gulf. We are here today with Dr. Pankaj Shrivastav. He's one of the best-known fertility specialists in the UAE and has been involved in reproductive medicine for over 35 years. He's also the doctor behind the first IVF clinic in the UAE. Dr. Pankaj, thank you so much for joining us today.
Thank you.
So I am curious, actually, as a woman myself who is married, we've been getting a lot of questions of the sort of, when are you going to have a baby? My husband and I. So as a specialist in the field of fertility for over 35 years, how do you feel about this question being asked to couples?
A lot of people nowadays get married and they want to settle down in their life and in their careers, be financially stable. And that's when they start thinking of expanding their family. What people don't realize is that humans, the human species, is a low fertility species. If you mate a cow, 90 to 95% of the time she will be pregnant. With humans, in any one cycle, the chance of a woman getting pregnant is about 20 to 25%.
Very interesting, because it's such a question that we hear on the daily, actually. It's a very ordinary question. We don't second think about it. But for a lot of couples, it's a painful question to be asked. So why can such an ordinary question that we hear all the time be so painful for couples?
If they've been trying for a while and have already suffered disappointments, then every little question like this is like a knife being twisted into your body. And that's unkind. It's cruel. So, it's difficult to tell people not to ask such questions. They think they're doing it out of concern. They think that they're trying to encourage you. Quite often, it does just the opposite.
Do you think that this fear, excessive fear that comes down to this issue has to do with medical illiteracy, say, or misinformation, or is it just a cultural aspect?
Young couples who haven't conceived, their first port of call is their local GP.
Mm.
And quite often, the local GP will try and figure out what's going wrong and try and help them, or if not, refer them to a gynecologist. Now, the girl's mother definitely has her own gynecologist, and she will recommend that her daughter-in-law or daughter consult that gynecologist. And sometimes it's sad to see that people have been doing this GP, general gynecologist kind of journey for 2 to 3 years. We ask, why have you waited so long? And they say, but I've been having treatment. And I use an analogy. I say, look, if you have a tumor in the brain, do you go to see a general surgeon? You wouldn't. So if you have a fertility issue, yes, gynecologists are very, very helpful to us. And they refer patients at the right time. They've done the basic investigations, essentially made our life easier. But do not spend too much time with that kind of treatment, because they can only do so much for you. Comes a point when you have to take the opinion and advice of a fertility specialist.
I love the analogy that you gave with the bodily issues and that you have to go to the adequate doctor for that matter. And so for the fertility issues, the first call should be to go to a fertility expert, which takes us to the next point, which is that you have been the doctor who took part of the first IVF clinic in the UAE. That was back in 1991, correct?
Correct.
Okay, so what made you dedicate your whole life to this one messaging?
This brings us to how forward-thinking UAE and Dubai has been. So the first test tube baby was born in 1978. I started training in fertility 9 years after that. So I started my fertility journey in 1987. And I was actually working in a well-known fertility center in London. There were so few fertility centers at that time. And the government of Dubai, the DHA, Dubai Health Authority, it was called DOHMS then, but they approached my boss, who was a pioneer. His name was Professor Kraft, Ian Kraft. And they asked him, would you please come and open a fertility center in Dubai? So he said, yes, I'm happy to do it, but I can't be there. And I will depute someone to set up the clinic for you and run that clinic. And he would make periodic visits once in 3 or 4 months. And they agreed to that. So in 1991, in Rashid Hospital, we set up the first IVF center, first fertility center. So we opened in July 1991. We started doing treatment in September 1991, and our first babies were born in July of 1992. So almost within the first 9-10 months, we had our first babies. And it was amazing. It made big headlines everywhere because this lady had triplets.
I want to clear up the biggest misunderstanding about infertility. That okay, I'm just going to give out a number. It's 99.99% of the time the woman's fault.
This is unfortunate. There is this stigma which used to be attached to fertility. In the old days, when we started in Rashid Hospital, couples would ask us, do you have an entrance from the back? They didn't want to be seen walking in through the front door of a fertility center. And I used to find it very strange. But then over time, when I came to know the society and the cultural environment here, you begin to understand. And this question always was asked by the man. There is this confusion in men's mind that libido and sexual powers correlate with fertility. There is no correlation at all. You could have someone who has perfectly normal libido and sexual powers but is unable to have a child because either he has no sperm at all or he has extremely poor sperm.
So now shifting the conversation to the male's fertility part, maybe we need more education and more insights into this aspect of the topic. So how often does male fertility play a role in the couple's conceiving?
In 35%, it is purely a male factor. Another 10-15%, it is a combined factor. So roughly half, 50-50. Sometimes the man already knows it. He's been married before, hasn't had children, never bothered to get tested. So we've seen a couple come in. They were a Bedouin couple. And this man came with 3 wives. And this is not recent. This is in the early days of 1990s. The wives have been tested all throughout. But he's never had a single test done on himself. And when he came there, the first thing I said is, I'm not seeing the wives. I want to see you first. And we did a semen test for him and found that he had no sperm at all. But he, in the process, has been married thrice.
This tells us that there is a stigma behind male infertility topics and them being publicly shared or publicly spoken about. So why do you think that is that men feel ashamed to get tested? And what would you say to a man who is fearful?
In couples where they're not able to conceive, and in half the cases, it's the man that is contributing to their infertility. But the big problem, as I said earlier, is this feeling that there is a relationship between fertility and libido and sexual powers. So the sooner one is able to dissociate those two, you can have a perfectly healthy man, very vigorous, with no issues at all, with the new way of living, the decrease in exercise, the obesity, the fast foods. These are still manageable nowadays with diet and Manjaro and Ozempic. These can all be handled. What is very, very worrying is the use of nicotine. in all its forms.
Okay.
Smoking, vaping, shisha, and midwak, all of them are essentially nicotine into your bloodstream. And that is very, very toxic to sperm. I say this to the girls as well. I didn't know whether you were aware, but a girl who smokes will reach menopause 5 years earlier.
Wow.
And if a husband also smokes, add 2 more years. So nicotine is directly toxic to sperm and directly toxic to eggs. Men don't want to believe this because they'll say, oh, but my friend smokes 40 cigarettes a day and his wife is pregnant with the 9th baby. And I say to them, no two people are the same. You may both have the same lung infection. I may give you penicillin and you may recover from it, and I give the other person penicillin and they may die from it. So do not look at your neighbors or peers or friends and say that what is happening to them, the same will happen with you.
So what would you say in terms of, for all the men who are listening to us today, what advice would you give them to kind of increase or promote a better fertility?
Cut out all the noxious elements in your life, the nicotine, the heavy alcohol, occasional glass of wine if someone wants. I have no objection to that. But do not indulge in what is very, very popular all over the world now, binge drinking on weekends. So cut that out.
So there are a lot of couples who would love to get help, but they don't know when it's too early or too late to get checked. So when do you think the couple should get themselves checked? After how long or after how many trials?
Their fertility has limits. Girls are born with the eggs that they need for their entire life. They start losing these eggs when they start menstruating. They've lost some eggs before also, but after that, and they keep losing these eggs at a fairly rapid pace till the age of 47, 48, 49, when they essentially run out of eggs. And that's when they go into menopause. So this is women. Men can go on for a long time. So that's why age is crucial. The woman's age is crucial when we are talking about how long you should wait. If a couple has got married and have been trying, the girl is less than 35 years of age, we say, try by yourself for a year. Because as I said, it could take a couple with absolutely no problem at all, 6 to 9 months to conceive. So why would you subject yourself to all sorts of investigations? Definitely do not rush in to see a fertility specialist or a gynecologist after 2 or 3 failed attempts. If the woman is over 35 years of age, as I said, the egg numbers are declining. The egg quality is declining. So girls who are over 35 years of age, if they've tried for 6 months and they haven't succeeded, then that's the time to take advice, consult a doctor, your gynecologist probably, because you're most comfortable with someone you've dealt with earlier also. But if you know of a fertility specialist or a center, by all means, you could go there. The third scenario is when you already know that there is a problem. The boy's been married before, no pregnancy happened, or the girl's been married before, no pregnancy happened. As a child, she had appendicitis and surgery on the abdomen, so you're worried that things may be stuck up inside the pelvis and the abdomen. The egg may not be able to find its way into the tube. Or as a young girl, she was diagnosed to have what we used to call PCOD, polycystic ovarian disease. That name has now fortunately been changed to PMOS, polyendocrine metabolic ovarian disease, which is so sensible because the first name PCOS was a misnomer. It is from 70 years ago, and it was still carrying on. So if the girl, as a teenager, was diagnosed to have PMOS, then that's someone who should probably go to a doctor earlier. Or she's been having this excruciatingly painful period from her mid-20s, and she's been diagnosed to have endometriosis. Someone like that, you wouldn't wait.
So, doctor, can you please walk me through how the first consultation goes for those who picture the worst?
When someone calls us and takes an appointment, the first thing we say to them is, please come together. So, thereby emphasizing that the problem may not be just related to the lady, there may be a contribution from the male side as well. And we like to see them together so that both of them are aware, as to what the discussion has been, what we found. At least we know where we need to start from. If the woman comes in alone or the man comes in alone and then goes and repeats the information to his spouse, we find that roughly 70% is lost. So we encourage couples to come in together. The first thing we do is take a detailed history. And this is an art, unfortunately, which is being lost. Because lots of times you can actually come to a diagnosis from just the history or the physical examination. Nowadays, it's all about investigation. A lot of girls will have families where there's a lot of diabetes, and especially in this part of the world, amongst the Emirati population, amongst the South Asian population, very high incidence of diabetes. Diabetes and PMOS are very closely related. The same condition causes both. So we elicit a family history. We do a semen analysis for the gentleman. We do an ultrasound examination for the wife, essentially to see what does her uterus look like. Does she have a normal uterus? Is the lining of the uterus normal? What do the ovaries look like? Does she have PMOS? Is she making follicles? Is she releasing eggs every month? So based on this, we decide on what specific investigations to do for this couple. I am not in favor of doing blanket investigations, sending out 20 different hormone tests. What you have seen, you make a diagnosis. Based on that diagnosis, you make the necessary investment.
So for couples who come in for a check, they don't immediately need IVF.
You'd want to try and achieve the best results with the least treatment. So there are so many simple things. Someone has walked in, you've made your investigations, you've tested her, found she has severe insulin resistance, she has PMOS, she's having periods once in 3 months or 4 months. You know that this is the cause for their infertility. So what I would do is advise first. I'm quite nasty actually when it comes to weight loss. If a girl is grossly overweight, it will compromise her chances of getting pregnant. And there's no point being gentle or politically correct about it. I tell them, you have to lose weight. It becomes the first resort. There you want to try and achieve the highest chance of success in the shortest possible time. If she's 25, I don't mind trying, controlling her basic problem and letting her try for 3 months, moving on to something simple called ovulation induction, or if that doesn't succeed, something called IUI, intrauterine insemination. These are simple techniques. These are simple treatments. There's no operation involved. And some of them do become pregnant, but the success rates are low.
So, doctor, in the case where the couple has a low AMH or a poor sperm analysis result, what are the solutions to this case?
Let's start with the AMH. If the girl is got a good AMH level, which means that she has good egg reserve, we are not so worried because we know that this girl has enough eggs. This doesn't always apply in cases where there is PMOS, because these girls, the old polycystic ovarian disease or PMOS now, these girls have lots of eggs. But as she ages, she may have lots of eggs, but that egg quality is poorer. So AMH, if there's a good egg reserve, various options are available. Time is on her side. But if she has low AMH, this is essentially telling us time is not on the side of this girl. She needs to be aggressive with her fertility treatment. Coming to the other side, if the semen quality is good, every option is available, provided the female doesn't have any major issues. You could start with something simple like ovulation induction, IUI, intrauterine insemination, or if that doesn't work, IVF. Because this sperm we have judged to be good enough to fertilize an egg on its own. However, if the sperm quality is poor, the count is low, the movement is poor, the shape is grossly abnormal, these sperms will not be able to fertilize an egg on their own. Even if I was to take out the eggs from the girl and put the sperms around the egg, this sperm would not be able to fertilize that egg. So for these men with really poor sperm quality, we cannot do even IVF. IVF or in vitro fertilization will not work. So we have a variation of IVF called ICSI, intracytoplasmic sperm injection. For the lady, for the couple, it's exactly the same treatment. But what we do with the eggs and the sperms in the laboratory is different. So in IVF, as I said, we would just take the eggs in a dish and put the sperms around them, and we expect 70% of the eggs to get fertilized by next morning. One sperm would have gone inside and we would see signs of fertilization. If we know that the sperm is of very poor quality, we know that if left to itself, this sperm will not fertilize the egg. So what we do is we identify the mature eggs, hold them under a microscope. We use a very fine needle. This needle is 1/10 the thickness of a human hair. With that needle, we pick up a single sperm, a sperm which is moving nicely. It looks nice, it has good shape. We pick up the sperm and inject it into the egg. That's why it's called intracytoplasmic sperm injection, or ICSI. It just had to get into the egg. After it's in the egg, it behaves completely normally. It fertilizes the egg, embryos form, embryos grow. We transfer the embryos back into the uterus. So ICSI is the treatment for men whose semen quality is poor.
You have mentioned earlier that PCOS, or PMOS, as newly attributed the name or abbreviation, is so common in this region of the world. So how does PMOS affect fertility in women?
PCOS was a complete misnomer. This condition was identified in the 1930s or 40s. And that name has stuck because the ovary is an innocent bystander in this whole disease process. But it's got this name that, or people think that the ovary is at fault. The basic problem is the same basic problem which causes diabetes, and that is called insulin resistance. So PMOS is a metabolic condition. It's a metabolic disease. What happens in these girls is they are born with insulin resistance, and this runs in families. You'll find their parents have diabetes, their uncles, aunts, grandparents, someone will have diabetes. So they've inherited it. Unfortunately, lifestyle makes it worse. Because when a girl puts on weight or grows older, the insulin resistance becomes worse. What does insulin resistance mean? It means that the normal amount of insulin isn't able to control this girl's blood sugar levels. So the body starts making more insulin, and finally the glucose will get into the cells, the blood sugar levels will be normal, and she will be fine. But that high insulin has lots of adverse or bad effects. And one of the effects is on the ovary. It gets the ovary of these girls to make more male hormone. So that's why you'll see a lot of them are having acne, pimples, they have some hair growth on their face, and that is the usual presentation of PMOS. So this is how you identify and test. So you check for insulin resistance. If there is high testosterone production from the ovary, it can arrest the development of the eggs in this woman. So this woman doesn't make an egg every 28-day cycle. She may not make an egg at all. And so that's the reason why they start having irregular cycles, once in 2 months, once in 3 months. I've seen girls who have one cycle in 1 or 2 years. So, of course, they go to the doctor and the doctor gives them medicines to get the period, but that doesn't address the basic problem, which is insulin resistance. So, we have to address that basic problem. I talked about briefly earlier: lifestyle changes, weight loss, exercise, diet, maybe these new medicines, Manjaro and Ozempic, because anything that can help them to lose weight will decrease their insulin resistance. We give them medication for the same purpose as well. And that reverses the whole system. Some of these girls who've come in saying, I want IVF, and I say, yes, but let me control your PMOS first. While they're waiting to control their PMOS, get pregnant spontaneously.
So I know many people, and I personally suffered my whole life with very painful periods to the point where I would pass out sometimes. So the initial thought was that maybe I have PMOS. Maybe it's this other situation where it's called endometriosis. Could you talk to me briefly about what endometriosis is?
Sadly, it's not uncommon, endometriosis, and sadly, it is capable of giving you excruciating discomfort and pain. And it's not just pain, it can affect other parts of the body. What is endometriosis? Every month, the lining of the uterus, which is called endometrium, sheds. And that's when a woman experiences a menstrual cycle. Endometrium, or the uterus lining, can also go backwards through the tubes and fall into the abdomen. Usually, the body handles it and destroys those cells, and that's the end of it. Sometimes this doesn't happen. And those cells keep growing and make implants. They make little implants on the surface of the ovary, or on the rectum, on the bladder, in the pelvis, in the abdomen, everywhere. And every month, when she's having a regular period, these implants are having a little period within themselves. So they're a tiny space of cells, and there's a little period going on, so it distends those cells. And that causes excruciating pain. They also release some nasty chemicals, which are also pain-inducing.
But is it normal to have a painful period? Because when I got the diagnosis, I did not have PCOS. I did not have endometriosis. So the final verdict was that, well, you just have painful periods. But is it normal?
It's called dysmenorrhea. It's called spasmodic dysmenorrhea. And unfortunately, it is not so uncommon. Usually, it's not very severe. And usually, as the girl gets older, it tends to become less severe. It never goes away. That's usually the case. But when the pain is excruciating, and sometimes it causes other symptoms, problems with the bladder, with passing urine, because there are these little deposits going on the bladder. If it's implanting on the rectum, for instance, these girls will they have an uncomfortable sensation wanting to pass stool frequently. So when it can even block the ureter, the tube that brings urine out from the kidney to the bladder, that can get affected and closed up by this tissue. So it can cause lots of problems. What it does is it causes adhesions to form. Adhesions means things being stuck together. Imagine layers of cling film. The intestine has come and got stuck to the ovary or to the uterus, and essentially everything may be working normally. The tubes may be working normally. They may be open. The ovary may be making eggs, but the eggs may not be able to enter the tubes. So the sperm never gets in contact with the egg. So this is how it can cause infertility. Unfortunately, the endometriotic deposits also sit at the top of the vagina, and it can make it very uncomfortable for the lady to be with her husband. It can cause a lot of pain at that time. So that is also another symptom. So usually it's these kind of symptoms that bring endometriosis to mind. Spasmodic dysmenorrhea usually isn't so severe.
So speaking of eggs, I would love to have your take on egg freezing, which is a very common topic that a lot of people talk about. Yes. And it can also be controversial sometimes.
Let me talk about how it started. So imagine a 16-year-old boy. He's been diagnosed to have a lymphoma or a testicular tumor or some malignancy. He's going to have surgery. He's going to have chemotherapy, which will kill his sperm producing cells. What would you do? He's 16, 18 years old. Before he starts his treatment, his doctor will send him to a fertility center. He would give us 2, 3, 4 samples of semen over a week or 10 days. We freeze them so that after his treatment, he becomes sterile. He's not able to have a child by himself. He's got sperm frozen. Once he gets married, he can bring his wife and we can use that sperm to make babies for this couple. This was always available. But for girls, this was not available. We did try to freeze eggs for these girls in the old days, but the technique of freezing eggs was very, very rudimentary and poor. So you froze an egg and you would only get 20 or 30% back when you thawed them. Then came this technique called vitrification. So vitrification is basically it means turning the tissue into liquid nitrogen and it turns into glass without damaging anything. So you freeze an egg, you vitrify an egg, 20 years later you take it out, it's exactly the same. So when this technique became available, everyone said, oh, if you can do it for cancer patients, why can't you do it for girls who haven't found Mr. Right? They're busy with their career. They are climbing up their career ladder path. You don't want to interrupt. Most important, they haven't found the right person. The parents would pressurize your time is, you're getting 36, 38, your time is passing by, marry the first person. That's not fair. Social egg freezing then came into its own, and now more and more girls are approaching us. It's not that they have a problem. It's that they want to be quite sure that the person they decide to marry and have a baby with is the person who will last them through their entire lives. The beauty is what you've frozen is what you get out. So if the girl has frozen her eggs when she was young, she may be 40, but she froze eggs at 30, you'll get
the
30
same
years.
Quality, same everything.
This is the beauty of it. And this is what I want to emphasize. Unfortunately, because it wasn't available earlier, we're now getting girls at 38, 40, 42 saying, I want to freeze my egg. I haven't found the right person yet. But the eggs that you'll be making at that stage may not be such great. We won't get so many and they won't be of such great quality. So if a girl is thinking of freezing her eggs, she should do it early. 20s is too early because she might still meet the right person. I would say early 30s is a good time, and I'll tell you why I say this. I'll give you a very nice story also with this. If a girl has frozen her eggs below the age of 35, she needs 12 to 14 eggs to give her one baby. When you thaw them, because not all of them may be normal, not all of them may be good quality. But if the girl has frozen the eggs after the age of 40, she needs 52 eggs to give her one baby.
That's such a big gap.
Yeah. So the earlier you freeze it, the less eggs you need to freeze, and the more likely you are to be able to achieve a baby from those eggs.
I don't remember when, but it clicked in my mind because usually when we hear designer, it's a bag, it's a designer bag, it's a designer shoe, designer jewelry. But I heard designer baby. Is that like something you get to design quite literally, or what is that?
It's partially true, but not in the way you're thinking. You can't order a baby with blonde hair and blue eyes and 6'3" and Nobel Prize winner. You can't. So that is what people think of designer babies, but that's not correct. But now science has really expanded, it has improved, and we can do certain things with the embryos before we put them back. And this is screening. So, for instance, we know that as a girl is growing older, the chance that her egg and embryo will have abnormal chromosomes is higher. That's why older girls, higher risk of Down syndrome, what used to be called Mongol babies, but Down syndrome is the common terminology. So it's because as they grow older, the eggs have more abnormal chromosomes. We can now check the chromosomes of the embryo before we put the embryo back. How do we do this? So we essentially have the girl going through IVF, and embryos are generated. We grow the embryos for 5 days. On the 5th day, we see which embryos are growing well. They should have reached a stage which we call blastocyst. So from the blastocyst, we are able to make a little hole in the shell of the embryo and suck out 3, 4, 5 cells. And after that, we freeze the embryo. These cells are sent to the genetic lab, and they can do multiple things with these cells. First of all, they can check the chromosomes, make sure that the embryo that you're choosing to put back has normal chromosomes. You are then able to shorten the time to pregnancy for this couple. She may have 10 embryos, only one is normal. Instead of putting one month after month, you know exactly which one to put back. The second advantage of something like this is families where there is a genetic disease. In this part of the world, you've all heard of thalassemia. You've heard of sickle cell anemia in Africa. We have lots of these patients coming, not just thalassemia. There are so many conditions which are genetically linked. They are related to a single defective gene. So when a couple comes to us, they've had a child who unexpectedly had this genetic abnormality of the father and the mother to figure out which abnormal genes do they have together. If they have common abnormal genes, we can then make probes to detect these abnormal genes in the embryo. And this is why cousin marriage within families is discouraged, because there is a higher chance that you can have abnormal genes in both the parents. So we can then look for that abnormal gene, rule out the embryos which are carrying that abnormality, and put back embryos which will not give this child a disease. And there's another positive thing that came out of this. I don't know if you've heard of this term, but it's called savior siblings. So we had a couple who had come in to us. They didn't know. They were completely normal. They didn't know that they were both carriers of thalassemia. So they didn't have the disease. But if they are both carriers of thalassemia, the child has a 25% chance of having the full-blown disease, which is terrible. It is a very unpleasant condition to be having. So they came to us. They wanted an IVF. We did an IVF for them, generated the embryos, and found embryos which are free of disease or just carriers like the parents. But we could also do a cell type match, what we call an HLA match. We were able to choose which embryo the HLA matches the affected child. And I'll tell you why. So she became pregnant with that child. That child grew up. They collected the cord blood from the baby when the baby was being delivered. That has got stem cells. Those stem cells can be used to do a bone marrow transplanted for the affected elder child. So he's a savior sibling for that child.
I'm sure, just as I was blown away with a lot of information that you have provided us today, a lot of the listeners will be as well. And I hope that every person who listens to this episode today takes away the good and the bad because you always have to be honest in order to.
True. And sometimes it can be harsh.
It's harsh honesty, but it's a helpful and useful one, and it's a much needed one.
For anyone who comes into our center, our tagline is, let's make you a family. You've come in as a couple. Let's help you achieve your goals of having a family.
Such a beautiful and close to the heart tagline, truly. Let's make you a family. Thank you so much, Doctor.
Thank you. Thank you so much.